what we're going to do is let Dr. Graff give a few highlights of the many things that happened in San Antonio. And then I will be joined with one of our leadership volunteers, Toni Willis, and together we will moderate the questions. So I'm going to turn this over to you, Dr. Graff.
Thank you so much for having me. So I'm going to start with a big disclaimer, which is that San Antonio Breast Cancer Symposium just finished on Saturday. So I certainly do not have every single presentation memorized. 2 days later, I came back Monday after a complicated travel weekend and was in clinic. So I'm synthesizing this data right alongside of everyone. And my second disclaimer is that everything presented at San Antonio is presented in abstract form, which is not yet peer reviewed. And so it's not its highest level of science yet. As things go through the peer review process, often statistical review just cleans the data a little bit better. And so sometimes we see things change as it enters the publication phase. And so we continue to wait for this data all to be finalized and just make sure that it is where we expect it to be. So I know there's many from the metastatic community on the call, so I'm going to start in the metastatic space, actually. The first trial I'm going to talk about that was presented at San Antonio this year is the Monarch 3 trial. Monarch 3 was a phase 3 randomized trial that took patients who had metastatic hormone receptor positive, so estrogen receptor positive and or progesterone receptor positive breast cancer, and randomized them to abemaciclib plus an aromatase inhibitor versus an aromatase inhibitor plus placebo. Patients were randomized 2-to-1 to the combination with abemaciclib, and 493 patients were enrolled in the trial. And what was presented at San Antonio was the overall survival analysis at a total in the final, hopefully one of the final follow-ups. And this study or this analysis showed that a improvement in overall survival was seen with an improvement of 13.1 months for the addition of abemaciclib, improving overall survival from 53.7 months for patients that received the aromatase inhibitor alone to patients who received abemaciclib plus the aromatase inhibitor having a median overall survival of 66.8 months for a hazard ratio of 0.84. But it did not meet its p-value for statistical significance because that hazard ratio crossed 1. Now, this showed an overall survival improvement with an improvement overall survival of 13.1 months. So I think there's some statistical problems with this trial. It's a two-sided alpha allocation, and I don't want to bore everyone with biostatistics. And it's a 2-to-1 randomization schema, which means that in the power of the study, it's an 80%. It's an 88% power allocation, which is actually a really high power allocation. And so all of those things sort of combined that meant that unlike Mona Lisa 2, which is the ribociclib trial, which had an 80% power allocation, it just was a lot harder for this much smaller study with a 2-to-1 randomization scheme to hit that p-value. But I think that huge difference in survival is hard to ignore. And for me, this is not going to make me shy away from using abemaciclib. Conversely, we had seen with palbociclib earlier on the Paloma 2 data that the overall survival data with that showed a change in 2.7 months with overall survival for Paloma 2, and it also didn't meet its p-value. And that delta, that difference in 2.7 months wasn't nearly as impressive as this 13.1 month improvement in overall survival. And so I think that's why you see a little bit of divergence in how we're talking about the Paloma 2 result with palbociclib versus this Monarch 3 result with abemaciclib across those two trials. The next trial that we saw in the metastatic breast cancer space was Anavol 120, which was a really unique population, which is, I think, one of the biggest key takeaways from that trial, which took patients who were first-line metastatic hormone receptor positive, PIK3CA mutant disease, hormone receptor positive, and had progressive disease within 12 months of completing their adjuvant endocrine therapy. So these are patients that had primary disease resistance, rapid progression, and a PIK3CA mutation. The population was a very young population. So when we look at the study, I have to look at my notes here a little bit more closely. About 40% of the patients were premenopausal. About 80% of the patients had visceral disease, so involvement in either their lungs or their liver. And the vast majority of the patients had progressed while they were receiving adjuvant endocrine therapy. And in that trial, we saw patients were randomized to either receive placebo plus palbociclib plus fulvestrant, which is the control arm, or Inofil, I don't even know how to say it, Inofilib, Inavolisib, which is a 9 milligram oral tablet. We're going to call it INA because I'm going to learn how to say it with everyone else, which is a PIK3CA, very potent PIK3CA inhibitor. In combination with palbociclib and fulvestrant, and palbociclib and fulvestrant. So that triplet was the intervention arm, and they received that until evidence of progressive disease. In order to be eligible for this trial, patients also had to have, because PIK3CA drugs can cause high blood sugars, patients had to have a fasting blood sugar of less than 126 and a hemoglobin A1C of less than 6. So my guess, they didn't tell us, my guess is that this was also a really healthy patient population, because to have a fasting blood sugar that's that low and a hemoglobin A1C that's that low means that these are all probably patients that are pretty thin, and certainly nobody with diabetes. And what we saw was that patients that were randomized to the triplet, so the new PIK3 drug, Anavol, improved median progression-free survival significantly, with a median progression-free survival improving from 7.3 months with the control arm to 15 months, so essentially doubling with the addition of the triplet. Now, I guess my questions about this trial is that the control arm did not include a targeted PIK3 drug in a PIK3 mutant population. And we do have now 2 therapies approved for PIK3CA mutations. We have alpelisib, we have capivasertib. So was that the best control arm? It also included palbociclib, which is the CDK4/6 inhibitor that we do not have clear data improves overall survival. So I know they used palbociclib because it's also probably the easiest CDK4/6 inhibitor to use in combination with other CDK4/6 inhibitors because of the side effect profile. So I'm not sure that this is the optimal triplet or the optimal control arm. And so we'll see where it goes. This is also a very specific, narrow population of patients, rapidly progressive, mostly young, PIK3CA mutant, hormone receptor positive patients. And so, very significant response to the triplet therapy. But how this will change our clinical practice, I think we need to see the publication come out. We need to get additional information on the subgroup and the tolerability. There was a very high rate of neutropenia. There was a very high rate of stomatitis, which means inflammation in the mouth. Also anemia and thrombocytopenia, all likely mediated by the palbociclib. and hyperglycemia mediated by the PIK3CA drug, and a 48% risk of diarrhea, which is obviously substantial. And I'm sorry, I may just have read my lines wrong. It may have been a 48% risk of 48% risk of diarrhea. So also some tolerability issues we need to work out.
Dr. Graff, I just seeing a question, so I just thought I'd interrupt you for a second.
Please.
Someone's asking, what is the mutation? Can you, not everybody knows.
Sure. So PIK3CA, what a great question. I have to think about how to describe PIK3CA. PIK3CA is an activating mutation that turns a cancer on and tends to tell it to divide more rapidly. So we have several different mutations that we are able to test for in hormone receptor positive breast cancer. Right now in breast cancer, we test for PIK3CA. We are really only testing for PIK3CA in hormone receptor positive breast cancer. It is a, again, activating mutation. So most tumors have PIK3CA present throughout the duration of that cancer being present. It's not a mechanism of resistance. It doesn't develop as a response to exposure to treatments. And PIK3CA is a protein that's involved in how that cell divides and grows. And so when it is mutated, it causes the cell to grow faster. The other mutations that we test for are obviously BRCA1 and BRCA2, which can be somatic in the cancer or germline in you as a human passed from your parents potentially to your children. And the germline mutations are targetable with drugs called PARP inhibitors. And then we also test for something called ESR1, and we'll talk about that in a second. ESR1 is a mechanism of resistance. It happens in the cancer as a result of exposure to hormone blockers like anastrozole, letrozole, tamoxifen, and the hormone receptor, the estrogen receptor, actually becomes mutated. And those medicines don't fit into that receptor as well anymore and makes basically a new receptor. And that new receptor has a different configuration. And so you need a different medicine to fit more neatly into that new mutated receptor shape. And that is something that we typically test for using blood-based testing after progression on prior hormonal therapy. I hope that helps. Thank you for that question, Jean. Okay. Next update that we got that I think is important is Her2Climb O2. Many of you have probably heard of Her2Climb. When we talk about Her2Climb, we have historically meant Her2Climb O1, which was a trial that used tecotinib, which is an oral HER2 blocking drug, in combination with capecitabine and Herceptin. Her2Climb O2, same trial name with a twist, completely different combination. So Her2Climb O2 uses tecotinib in combination with TDM1. The brand name of that is Kadcyla. And so TDM1 is an IV medicine that's given once every 3 weeks. And this trial, Her2Climb O2, took patients who had progressed on first-line therapy for HER2 positive metastatic breast cancer and randomized them 1-to-1 to TDM1 or TDM1 plus tecotinib. At the time, that was the standard of care, and followed them for progression-free survival as the primary endpoint. And Dr. Hurwitz presented that primary analysis and showed that the combination did, in fact, TDM1 plus tecotinib, improve progression-free survival from 7.4 months for TDM1 alone to 9.5 months for the combination. Now, since Her2Climb O2 was designed, we've seen the results of Destiny Breast O. I'm going to get my Destiny Breast O confused. Destiny Breast O2 showing Destiny Breast O3 showing trastuzumab deruxtecan in this space. And so compared to what trastuzumab deruxtecan improved progression-free survival for HER2 positive metastatic breast cancer in the second line, this is a less dramatic response. And so I think that the audience at San Antonio saw an improvement from 7.4 months to 9.5 months and said, yeah, okay, that's better. But maybe not this huge response that we were hoping for. Just like with Her2Climb O1, Her2Climb O2 did allow patients to go on who had stable brain mets, untreated brain mets as well. And we saw a similar benefit in patients who had stable or untreated brain metastasis from 5.7 months to 7.8 months in that population. So overall survival data is still pending. My takeaway from this trial is that this does make the Her2Climb O2 regimen a reasonable option for second line therapy in HER2 positive metastatic breast cancer. But I think trastuzumab deruxtecan is going to be our standard. But I think for patients everywhere, it's important to have options because trastuzumab deruxtecan may not be the best choice for everyone. They may have lung disease that makes that not an option for them. Trastuzumab deruxtecan is being evaluated in the first line setting. And so if it ultimately gets approval in that setting, Her2Climb O2 gives us clear evidence that we can use tucatinib in second line. And then because of the way that patients with brain metastasis are included in this population, it gives us added data for patients who maybe are having more active disease in their brain and how to consider that brain metastasis population. Although, again, data continues to emerge for trastuzumab deruxtecan in the brain metastasis population as well. So lots of data that is bouncing around. And again, I think we're going to wait for the lots of data that is going to emerge in the as we see the publication come out. And I think those are probably the big ones I wanted to review. And then I'm going to let Jean hit me with questions, and then I can go over some early stage updates too, if Jean doesn't have too many questions for me.
No, we have a lot of questions. So I'm going to bring on, but I want to make sure we include early stage, but let's bring on Toni Willis, who is a newly trained Hear My Voice advocate with Living Beyond Breast Cancer. She joined us in San Antonio. She is living with metastatic breast cancer, and I'm so happy to have her because she's going to help me sort through these questions. So welcome, Toni.
Thank you.
Thanks for, go ahead.
Yeah, Dr. Graff, before you move on from the HER2 population, there was a question. Is there any information about the long-term effects of being on Herceptin and Perjeta plus an AI for triple positive breast cancer? This person has been on for these medications for approximately 4 years.
There is not. I mean, we have long-term follow-up on Herceptin, and there's not been any late toxicity reported. So, I mean, I certainly have patients that have been on Herceptin and Perjeta for 10 years plus, and we haven't had any negative late reports even to the FDA and to watch dog groups. There is a current clinical trial enrolling called Stop HER2. Dr. Parsons at Dana-Farber is the PI that is enrolling patients who have either stable disease or no evidence of disease that are on HER2 targeting therapy alone without a chemotherapy backbone. So, for example, somebody who is on docetaxel, Herceptin, Perjeta, stopped the docetaxel and now has chugged along for many years on Herceptin and Perjeta alone. And after stability for a while, the trial randomizes you to stop those medicines. And then you enter active surveillance with frequent scans and it is testing the hypothesis that those patients can safely stop that therapy, which we've seen in other diseases, for example, melanoma with immune checkpoint inhibitors. And so I offer that to anyone in the audience that is on those therapies and is interested in participating in a trial testing that concept. I myself have referred patients for that option.
Yeah, it's so exciting. We actually have, if anyone is interested, we do know a couple of women who are in the STOP trial, and what an amazing thing to get to that point in metastatic breast cancer. So I'm just going to ask, there are a new class of drugs that have been approved, or at least one, SERDs, and there are just some questions. Can you explain what is a SERD? And I know you talked a little bit about the trial, but maybe I know there are more coming in trials now.
Yeah, so the SERD, selective estrogen receptor degradator, or SERM, selective estrogen receptor modulator, are our new class of anti-estrogens. And they are selective because they block the action of estrogen in breast cells, but not necessarily other cells, although the selectivity of those medicines is variable depending on the medication. For example, our oldest SERD is tamoxifen, and the reason that it's not 100% selective for breast tissue is also why we see a slightly higher risk of endometrial cancer or uterine cancer with tamoxifen, is because it also has some estrogenic properties in the uterus, and why you can see some other anti-estrogen effects. And they work by by degrading the receptor so that estrogen then can't bind that breast cancer, which is really sort of the gasoline that's fueling the fire of the breast cancer. And so by binding the receptor and downregulating it, or modulating that receptor, deactivating that receptor, it allows the cancer to neutralize in a way that helps it not continue to grow. So right now, in addition to fulvestrant and elacestrant, so fulvestrant Faslodex is our oldest estrogen, our oldest SERD. Elacestrant is our newest SERD and is oral. There are numerous other ones that are on the market and being evaluated, including imlunestrant and lasofoxifene. And we will figure out which direction we go from here.
Mm-hmm.
Go ahead, Toni.
Well, this is sort of a general question, but it's the question is there anything new for triple positive early stage breast cancer?
Any new directions for triple positive early stage breast cancer?
Mm-hmm.
Yes. So with triple positive, so frustratingly, for the triple positive, or co-positive is my language, and I apologize, I'm going to switch words on you. For the co-positive community, we don't often talk about it like that, which I know is difficult. You're not going to see a trial published that says, hey, for the co-positive world, we tend to focus on the front side on HER2 positive, and then on the back side on hormone receptor positive. So a patient who is co-positive is going to be eligible for many of the HER2 positive chemotherapy neoadjuvant or adjuvant trials, and then many of the hormone receptor positive adjuvant studies. And so you have to sort of piece together the data, and that is difficult. I would love to see the data reported in a way that made it a little bit harder to see the truth of your cancer experience for patients that are co-positive. Right now, in the HER2 positive early stage breast cancer space, there are several trials going on looking mostly. So, right now, we give neoadjuvant chemotherapy, most often with a taxane, Herceptin, Perjeta based chemotherapy regimen. And then based on response at the time of surgery, if a patient has what we call a pathologic complete response, it means your cancer is totally dead and gone at the time of your surgery. What is surgically removed is just dead cancer cells or nothing left there. Great, you can finish 1 year of Herceptin, but if there is still residual cancer, the risk of recurrence is slightly higher. And in that scenario, patients are changed to receive TDM1, the medicine we spoke about earlier. So there are several trials right now looking at doing something different than TDM1. So there are trials looking at trastuzumab deruxtecan, and there are trials looking at adding tecotinib to TDM1. And so I think that both of those trials will report out in the not so distant future, maybe in the next 2 years. And then in the hormone receptor positive space, there are several trials looking at those SERDs that we were just talking about, elacestrant, imlunestrant, et cetera, using those in the high risk hormone receptor positive population, so mostly positive lymph node patients, to see if we can improve upon the outcomes that we're currently getting with medicines like anastrozole and letrozole. And if not improve upon the outcome, improve upon the toxicity profile by offering those medicines as an alternative. But none of those are ready for prime time yet.
Okay. I know there's a lot of questions in here. I just want the audience to know that weren't related to
I just looked at the Q&A box and there's over 60. I'm like, wow.
So I want to try to focus on what was reported on, but were there any updates on the use of immunotherapy in either early stage or metastatic?
Yeah, so I can give two quick, I'll just do the quick early stage breast cancer updates very quickly. So there were several updates from surgery and radiation oncology, mostly looking at what to do about lymph nodes after neoadjuvant therapy and what to do about radiation after neoadjuvant therapy. And just in the interest of time, the Cliff Notes version is less is more, and a good response to neoadjuvant chemotherapy can be believed. So for patients that have a pathologic complete response, we can use that pathologic staging to drive our treatment decisions, which is fantastic. All of those are really practice affirming. Many major institutions that already sort of shifted to practicing that. And I think that should drive change in most of the major guidelines that hadn't already shifted. In the treatment landscape, we did get some updates on immunotherapy. We saw an update on a trial called Keynote 756, as well as a trial called Checkmate 7FL. And I'm gonna talk mostly about Keynote 756 because they're very similar, and I think that it's again just big picture. Keynote 756 is not practice changing yet because we need longer term follow-up on the data. But Keynote 756 is a trial that took patients with high risk hormone receptor positive early stage breast cancer. And high risk is defined as either positive lymph nodes or large primary tumors. So tumors larger than 5 centimeters or positive lymph nodes, and grade 3 tumors. It did include patients that were what we call ER low, so patients that had estrogen receptors of less than 10%, but not exclusively that population, and randomized them to receive standard chemotherapy, which is doxorubicin cyclophosphamide, AC as we call it, or followed by Taxol, or that same combination with pembrolizumab. So essentially the Keynote 522 regimen that some of you might know from early stage triple negative breast cancer, neoadjuvantly, followed by surgery. And then depending on their response, patients then would go on to receive another 6 months of pembrolizumab. And what we saw was that at this interval analysis, patients that received the addition of the pembrolizumab had a significant improvement in the rate of pathologic complete response. Now, again, this is hormone receptor positive disease, so we don't get the sky high rates of pathologic complete response that we see in triple negative breast cancer, but the rate of pathologic complete response improved from 15% to 24% with the addition of pembrolizumab. In the Checkmate trial, which is similar using nivolumab, we also saw a similar improvement in pathologic complete response rate. On subgroup analysis, which was really the key presentation at San Antonio this year, they broke that down by several biomarkers, including PD-L1. And what we saw was that in patients that were very PD-L1 positive, which was a CPS score of 10 or a CPS score of 20, that pathologic complete response rate reached 40 to 50%, depending on the PD-L1 status. And I think that this really tells us that there is a proportion of hormone receptor positive breast cancer patients that are very immune sensitive to medicines like pembrolizumab. Before this is practice changing, we will need to see event-free survival follow-up. And that has not yet been reported. Immunotherapy comes with a lot of side effects, and we will not do that lightly as a breast cancer community. Mm-hmm. We also saw longer-term follow-up on Keynote 522 in the triple negative community. This, of course, has been standard practice now for many years. So the update we saw actually at ESMO, but I'll give it to you today because we're talking, was the 5-year event-free survival by rate of pathologic complete response, and then some subgroup analysis, including on the lymph node negative breast cancer patients. And we really saw that all patients, even stage 2 lymph node negative and T2N0, which are patients that I kind of don't love giving all this extra treatment to, really benefited from the addition of the pembrolizumab. So really solidified that Keynote 522 is a well-designed trial that selected a good group of patients to receive this added combination of therapy.
Do you have a question, Toni?
I do. I know there was a lot of discussion about this topic. What is the utility and use of CTDNA testing for monitoring cancer?
So I do not think that CTDNA is prime time for monitoring cancer. I would encourage anyone who's interested in that to look for trials that are in their area that are analyzing CTDNA for monitoring cancer recurrence. And the answer is so complicated. I'm sorry. This is a hard question, Toni. You don't even know how hard of a question you just asked. So part of it is that the tests aren't perfect, right? So I'm going to use. I actually presented the CTDNA feasibility cohort from Monarch E. So I'm going to use that one because I can quote the data to you very quickly and easily. In that cohort, which was enriched for patients at an increased risk of recurrence. Like we selected a very high risk of recurrence population to do the feasibility pilot on. The false negative rate, so the likelihood, the patients that were persistently CTDNA negative, who had their cancer recur anyway, was 21%. So doing a CTDNA assay to say there's nothing for me to worry about isn't true. And in that feasibility cohort, there was 30% of patients that were CTDNA positive, took their prescribed therapy, and cleared their CTDNA and have no evidence of cancer recurrence. So having a positive CTDNA doesn't mean all hope is lost. It means that you should keep on keeping on. And so at this point, I don't know what to tell somebody who has a CTDNA assay, other than that I have quadrupled their anxiety and my anxiety. And so I think that it's a really, really important question. But I want to make sure that we are asking that question in a way that is thoughtful and benefits everyone, because that's how we learn and grow. And I don't to do a test that is not reliably informative and that we don't know how to respond or react to is hard as a physician to then counsel someone on.
Yeah.
Thank you for being so transparent. And Living Beyond Breast Cancer has covered this topic and will continue to write about it. So if anyone wants to know more, feel free to reach out. Hopefully it holds promise in the future. It would certainly be really great to predict if treatment wasn't working well earlier. I'm going to try to give you an easy question. I think there was data presented. Is a lower dose of Verzenio as good as the higher dose so that you can reduce the side effects?
Yeah, we saw that. We actually saw that at ASCO 2023 that in patients treated with abemaciclib, that patients that were treated at patients that had a dose reduction did not have a worse outcome than patients who did not have a dose reduction. Now, I would add the caveat that those patients were dose reduced because they were having side effects on clinical trial. And so it may be that when side effects drive your dose reduction, it's a biological marker of how you respond to the drug. So that's a little bit different than just starting your dose low. Similarly, in adjuvant, so early stage ribociclib, the trial design used a lower starting dose based on a biologic rationale for that lower dose. So instead of in the metastatic setting, a ribociclib is approved at 600 milligrams, and in the adjuvant or early stage disease, the trial at Natalie is using 400 milligrams. And there's a scientific rationale for that.
That's great. You explained that really well. Thank you. Toni, got a question?
Well, and I think, triple negative breast cancer hasn't really been discussed much today. Are there any new, were there any new reports at the conference about treatments for triple negative breast cancer?
Great question. Thank you. You're right. This was not a big year for triple negative breast cancer. I feel like we do this roller coaster thing where we research drugs and then a bunch of stuff comes out and then nothing comes out and then we're researching new drugs. So like we have a HER2 year and then we have an ER positive year and it roller coasters. So right now in triple negative breast cancer, there's a lot of work being done with the antibody drug conjugates. Obviously, the work being done on trastuzumab deruxtecan for HER2 low extends to the triple negative breast cancer space. There were no new updates at San Antonio Breast for HER2 low, but I'm sure you saw many of those already at ASCO. If not, Google will bring those all to your inbox. We did get an update at San Antonio Breast on Tropion-01. Tropion-01 is using a drug called datopotamab deruxtecan. Nobody can say that. We all just say Dato-DXd. Dato-DXd, I lovingly call the love child of sacituzumab govitecan and trastuzumab deruxtecan because it's a little bit of both. It is a TROP2 antibody like sacituzumab govitecan that has a deruxtecan payload like trastuzumab deruxtecan, see, love child. So antibody drug conjugate. The Tropion-01 trial that was presented first at ESMO and now an update at San Antonio is the hormone receptor positive cohort, but that drug is also being studied in triple negative breast cancer. And we know from the phase 1 trial that it was highly active in triple negative breast cancer. We just haven't received the publication. I don't know, but I think we should see that hopefully at ASCO, but I guess we wait. The Tropion Tropion-01 update that we got at San Antonio was just some additional subset analysis that showed us time to subsequent therapy, which was sort of a random update. I think that they had probably expected to be able to give us overall survival and had asked for the presentation slot, and then not quite been there in terms of events to be able to analyze the data for that. But their time to next treatment with Dato-DXd had improved from 5 months to 8.2 months, which is a great endpoint. Progression-free survival was better depending on how long you had previously been treated with CDK4/6 inhibitors. So patients that had had a more durable response to prior CDK4/6 inhibitors had a more durable response to Dato-DXd, which again, I don't think is surprising data.
Thank you. We do have a couple of questions from people about lobular breast cancer. I'm not sure if you know if there were any updates on either the diagnosis or the treatment.
Yeah. The most interesting lobular update is actually really random, and it was a pathology-generated AI update that there's this really great pathology tool that uses AI, artificial intelligence, to analyze the slide to predict whether or not the breast cancer specimen has a CDH1 mutation. I'm sure many in the lobular community know that patients that have a germline CDH mutation are that germline mutation is linked to a risk of lobular breast cancer, and depending on your lobular breast cancer, you may be at higher risk for having a CDH germline mutation. And so just this AI generated analysis of the slide can predict with pretty high sensitivity if that mutation is present, because patients with hormone receptor positive breast cancer are less likely to just qualify for genetic testing. In many sort of nomograms of how patients are eligible for germline genetics, this is a great resource that could potentially open up the ability to identify patients that are at risk to have a germline genetic alteration, especially in lower resource places. For patients with metastatic disease, NCCN recommends genetic testing for everyone, but especially in the non-metastatic setting, I think that that's really a powerful tool. There is lots of, the discussant of that data did a really nice job pointing out just flaws in the way that the statistics are analyzed. Like, it needs to be confirmed on an independent cohort before it's ready for prime time. But I think, really, really interesting application of AI.
Great. So I know time goes so fast. We have 5 minutes left. So Toni, I'm going to let you ask a question. I think maybe we can do 2 more.
Okay. And I don't know that this was discussed at the conference, but there is a question about whether you think that cryoablation will ever be approved and utilized for early breast cancer treatment.
Yeah, not discussed. I do think approved is a tricky word, right? Like I think the technology of cryoablation is an approved technology. Whether it will ever be Category 1 NCCN guidelines is an entirely different benchmark to clear. Just like knowing whether or not there's a lot of selection bias in non-surgical trials. And it has been historically very, very difficult to accrue to those trials and to have patients adhere to the randomization of surgery versus non-surgery trials. And that is true in early stage breast cancer stage, 1, T1A, T1B trials, and DCIS trials. Comet being the most recent example in DCIS. And so that is probably the biggest barrier to making cryoablation a clear guidelines-driven endpoint. I hope I just answered the question. I think it's still something that can always be discussed depending on the technical aspects of the breast cancer.
Right.
Right. So I wonder, because we're getting a couple of these questions, Dr. Graff, if you could let us know what gives you the most hope from San Antonio this year. And it might not be that something was approved or something was practice changing, but maybe something that you're following and are hopeful about.
The patient advocates at the conference. I moderated a session with Abigail Johnson, who I'm sure many of you know, and she just was the star of the meeting for me. I love the way that San Antonio does a really great job including patient voice. Some sessions better than others, obviously, but it's so powerful to hear patients stand up and be able to share their story. It's so powerful to hear patients at the microphone challenging the scientific community about everything from this drug being well tolerated to where we go from here, to trial design, to how we communicate these results. And so just seeing that play out on an international stage really gives me hope that we're headed in the right direction.
That's a great answer. And I know the session you're speaking of, and of course we know Abigail Johnson, and she's such an incredible advocate, really even questioning the FDA about why certain approvals were made in a certain way. So, because that was going to be my final question too, because some people are saying, what is the role of patient advocates in San Antonio? Because many people have never been there. I thought maybe both Toni and Dr. Graff could give your insights on that.
Well, Toni, I think you should go first.
Yeah.
Sure. Well, this was my first year attending the San Antonio Breast Cancer Symposium, and it was just wonderful to meet so many other advocates, to get a chance to talk to the physicians. I even ran into my MD Anderson physician there, so it was interesting to talk to her in a non-clinical setting. But it's nice to be able to have our voice and to have our voice heard in various different arenas in that conference. And you're right. I think it is important for the researchers and the clinicians to be able to hear from us as they're hearing about the new information that's becoming available for the treatment of breast cancer. And it was a very rewarding experience for me.
And Toni, you should note that you are a physician yourself, right?
Yes, I am. So it was very interesting to attend a medical convention, but for very different reasons. And so I think that, it's been good for me to be able to apply both my medical knowledge and then my knowledge of, living with this disease for the past 10 years. Early breast cancer was diagnosed 10 years ago, and then I've lived with metastatic breast cancer for 8 years.
So, from my perspective, the role of advocates at San Antonio is, a millionfold. One, obviously, many of you saw that they have a role in programming. They have a role in abstract review. So they sit on the planning committee. They decide what's going to be at the podium. They decide what abstracts are going to be presented. Then they sit in those sessions and are able to respond to questions, respond to the presentations. Obviously, all the clinician scientists that are involved in the sessions pay heed to that at various different levels, and we can all continue to raise our voices to help make sure that they're elevated to the level that they need to be. But that can be done beautifully and powerfully. And I think that there were clear examples of times that the patient advocate was just the star. And so that's really refreshing to see. I also think that for me as a clinician and a scientist, San Antonio is just as much about the meetings behind the meeting as it is the meeting. Often I go and I know all the science that's being presented because I've been on the publication teams and I know it already. It's more that I'm meeting behind the scenes with the drug development companies, with the cooperative groups, with my collaborators, and talking about what comes next. And it's so fantastic to be meeting new patient advocates and being able to pull them into meetings as well, or ask them their takes on the data and what they're interested in seeing develop, and collaborate on ways to grow from there. And then there's advocacy training sessions. So it's also about getting the next generation of advocates to take the stage in their right time as well. So, I think that there's loads of opportunities for patient advocates at the San Antonio Breast Cancer Symposium.